Hello and welcome to this afternoon's digital event around smoking cessation and severe mental illness. My name's Rose. I'm part of a social enterprise called Kaleidoscope Health and Care, and I'll be hosting today's webinar alongside my panelists today. If you have any technical difficulties, if you'd like to share the video with a colleague, or if you enjoyed it so much that you'd like to watch it again, don't worry, because we will be recording this event and you'll be able to find it on YouTube later. So today we're going to be exploring the topic of smoking cessation. We'll share learnings from the research project so far, and we're going to explore how we can put these findings into practice. So this webinar is part of a wider project which is commissioned by VCSE Health and Wellbeing Alliance, which is a partnership between Department of Health, NHS England, Public Health England, and 20 national voluntary sector organisations and consortiums. So the Alliance aims to bring a voice to the voluntary sector and people with lived experience into national policy making to promote equality and reduce health inequalities. So the Association of Mental Health Providers, Centre for Mental Health and Rethink, as members of the Mental Health Consortium, are leading on this project in particular, alongside health and wellbeing partners. So it's involved extensive engagement with people with lived experience and the VCSE sector, and will culminate in the production of a suite of resources, including a report to outline the findings and case studies, which Curtis will talk about in a little bit. So I'm delighted to introduce my panel today. We've got Curtis Sinclair from Centre for Mental Health, who's going to share his research to date. We have Kevin James, who's a peer consultant, who's going to share his lived experience. And we have Cilia La Corte from NHS England, who's going to share the policy perspective. We've also got Peter on tech and Chloe on Q&A. So please do start sending those through. So we're going to start with a quick poll to see who's tuned in today. So on screen, you should see a few options. If I had to pick, I'd describe myself as. So as you can see, it's clinician or practitioner, someone with lived experience, someone working in policy or VCSE, researcher, or something completely different. Great, so we're going to close the poll there. Great, so it's great to see you've got quite a mix of people tuning in, so especially in sort of clinician, practitioner and people working in policy and VCSE. Thank you, Peter. Great, so there's lots of different ways that you can get involved in this webinar today. As you can see from the slide, which will be on your screen now, you can use the Ask a Question feature on your screen. Just click the question button, type in your question, and we'll come to your point in the discussion. You can email us at hello@kaleidoscopehealth.org.uk. So please send through any suggestions, comments, advice or questions. And also please do tweet. We're using hashtag SMI smoking cessation and hashtag HW Alliance. And our Twitter handle is Kaleidoscope Health. Brilliant. Cool, so we're going to go on to our second poll for today. You'll see on the screen, we want to sort of get an idea of how much you know about this topic. So on the screen, you'll see different options, including nothing at all, a little bit, quite a lot, a personal experience, or I could write a book on it. Great, thanks, Peter. We'll close it there. Cool, so you'll see the results on the screen. So a mix of people tuning in, from people who know just a little bit about it and to people who know quite a lot. No one's written a book on it just yet, but maybe at the end of this webinar they might be able to. Brilliant. So next I'm going to introduce Curtis Sinclair, who's going to talk about the research to date.
Thanks, Rose. Good afternoon to everyone joining us. I've got a very small window to provide a brief update on the work that we've been doing on the smoking cessation research project, including a bit of background to the project and what work has been completed, and also to touch on some initial findings. Can I have my first slide, please? And then, sorry, the next one as well, please. So just to give a brief overview of the context and the importance of this project. Certainly it's rooted in the poorer physical health outcomes faced by people with severe mental illness, and smoking contributes disproportionately towards issues such as reduced life expectancy and several other health inequalities in comparison to the general population. In addition, this group are more likely to smoke than the general population and to smoke more heavily. Yet interestingly, motivation to quit is no less than that of the general population. And it has been argued that what works for the general population also works for people with severe mental illness. But before reaching this stage of offering support, it makes sense that we must know who needs support and how many people require access. And unfortunately, this is one of several problems that are flagged up in the literature in the current pathways that severely hinder the support being offered to people with severe mental illness and to quit smoking. Therefore, the aims of this project, broadly speaking, were to identify these gaps, but also to shine a lens on examples of good evidence-based practice. And on the next slide, you'll see that we've taken a mixed method approach to achieve the aims set out, drawing information from surveys, workshops conducted by Rethink, interviews and case studies, much of which has been informed by a comprehensive literature review, which was undertaken by my colleague Jo Wilton at the Centre for Mental Health. And it was hoped that this approach would help to draw out both lived experiences around accessing smoking cessation services, but also the views of professionals who might be asked to support or commission services. And after today, with all the workshop and interview data collected, I will begin the process of thematically analysing the data. And you'll see on the next slide a summary of the more pertinent emergent themes from the literature review. And for me, one of the central issues relates to the beliefs and norms held by either the person with severe mental illness, significant others, and/or healthcare professionals. For instance, in the case of healthcare professionals, what came out in the literature review and to some extent the survey data is that it's not uncommon for smoking cessation to be viewed as a difficult process that should be avoided. Also, compliance, both for the service user and the service provider, are also pivotal in creating the conditions for a successful quit attempt. For instance, attendance at less than 75% in a particular study was predictive of relapse. And the emergent themes from the survey and workshops on the next slide lend support to the wider findings outlined in the literature review. Respondents were primarily heavy smokers who had made at least one quit attempt in the past and reported willingness to try again in the future. Typically, participants were motivated to quit, but often lacked confidence in maintaining abstinence. And in some cases, certainly in the workshops, some felt smoking was a good stress reliever. Lack of access to support individual needs was apparent, such as feeling as though options were limited to nicotine replacement therapy rather than other pharmacotherapy options. And in terms of what helped people to quit in the past or might help in the future, included drawing on personal qualities, e-cigarettes, gums and patches. But more importantly, there was a great range of individual variation in what was reported to be useful, and this lends support to the finding from the literature for taking a much more tailored approach to smoking cessation. Responses from commissioners and practitioners who tended to be working within the NHS indicated that main challenges identified were low success rates, high relapse rates, low success rates, high relapse rates, lack of uptake of services, and lack of appropriately skilled workforce. And typically findings were again in line with themes from the literature review. And I want to finish with the next slide by highlighting several excellent sources of research and guidance to draw from in helping to better design effective services. In the case of the Scimitar and Care to Quit, these are great examples of adapting general population manualised approaches specifically for working with people with severe mental illness. The Ask, Advise and Act guidance by Action on Smoking and Health tackles one of the major issues already raised across surveys, workshops and literature to tackle the capturing of who smokes, but more importantly, providing some immediate follow-up actions regarding smoking cessation. And the references to the other sources will be made available after today's session. Hopefully that gives you a flavour of what is to come in the shape of a final report later in the year. Thanks.
Brilliant. Thank you, Curtis, for sharing the key findings from the research so far. We're going to go on to the slide again about how to get involved today. So if there's any sort of key reflections you have from Curtis's session, then please do send through comments, reflections and questions to us. We'll also have the slides available as a handout, which you'll be able to see in the GoToWebinar function as well. Great. So next we're going to talk to Kevin, who is a peer consultant and is going to share his lived experience of this topic. Kevin, you've heard about the key findings from the literature review. How does this resonate with you?
I think what it identifies is that it's a very complex area of healthcare, and certainly that, you know, I think the findings identify that for people who need to be able to engage with smoking cessation services, that there needs to be more than just one size fits all approach to how we engage with people. So I think how we can best help people to get the best out of services is I'm really interested in the aspect of patient flow and also making every contact count. So wherever a personal lived experience, a service user presents themselves, whether it's a GP surgery, whether it's that they unfortunately need to stay on an inpatient ward, wherever it may be, that there's a consistent approach and a consistent conversation with people about what options there are in respect of helping them to achieve their goal. If their goal should be that they want to give up smoking, help them to best access that. So the patient flow bit, I mean, is that there needs to be smoking cessation classes on inpatient wards. There needs to be conversations with people who need an inpatient stay about how best to help them if they have capacity, that is. I think the complexities start to creep in when it might be a short inpatient stay for somebody, and then they're back out into the community. And it's about that lack of a joined up approach. So once you then go back into the community, if you are supported by a community mental health team, are there smoking cessation advisors based in those teams? Are there classes? Are there psychological interventions that people can access? And indeed, the same for primary care. If you are discharged back to your GP, where is that consistent joined up conversation? That consistent conversation, because with me, it was about, you know, I definitely wanted to give up smoking, knew the harmful effects of smoking. However, I was battling with socio-economic challenges that meant that I wasn't particularly at a stage where I could give up smoking. So, you know, whilst people are trying to navigate the housing system, trying to get, you know, a stable, affordable housing, whilst they're trying to navigate the NHS or the benefit system, you know, it doesn't. I guess the one focus on it needs to be right for the individual, and we need to accept and acknowledge and respect that it needs to be right for the individual when they're ready to make that choice, and always to be there to support them and be mindful that, you know, certainly for myself, it took many attempts to be able to quit smoking. I think also about how it's about changing the nature of the conversation as well. So everybody knows, a bit like with your physical health, you know, less input, more output. So eat less, exercise more. I think you know, people need to be aware of the facts that can really give them the incentive to maybe want to give up smoking. So for example, if you do quit smoking successfully, maybe you can reduce your medication by 50%, for example. So 50% less mood stabilizing medication, say less weight gain, less side effects of craving sugary, starchy foods, you know. But I think, you know, I think what the report has identified is that we are at a crossroads. We really do want to enable, empower, support people to make better lifestyle choices, but the reasons as to why people continue to smoke are very relevant and very important. So people would smoke because it's they perceive that it may be better for their mental health. So having a cigarette calms the nerves, soothes you. It's also the action of pulling out tobacco and rolling a cigarette, if that is the way that you smoke, and smoking it. And so it's about it's about finding other ways that people can engage, and how we can maybe detract people away from thinking that smoking is a coping mechanism for them. And I'm sure it is, but we need to present other options that work far more holistically for that individual, other than them choosing to smoke. And also, smoking poverty. People will be smoking and not being able to afford to buy healthy food or paying their bills, and then you've got counterfeit tobacco. There's all sorts of real challenges and that people find themselves in when they continue to smoke. I think we've got to get better at how we consistently are there to enable and support and empower people to make good lifestyle choices in respect of smoking, but understand it's really complex for that individual, and we need to come up with a range of different interventions and support mechanisms that can enable that person to give up.
And I think that reflects a lot in terms of what Curtis was saying about around the need for individual support and sort of personalised support as well. I wonder if you could talk a little bit more about sort of need for tailored support and sort of how that fits in as well with different sort of services.
So tailored support. So I guess I think when I first started getting, I'm a reformed smoker, so I'm probably one of the worst people you'll meet as a reformed smoker, because I'm very critical of other people who do smoke. And I remember the whole kind of conversation early on about becoming smoke-free in NHS hospitals, and I thought that's a really good thing. But what I've learned since then, after speaking to many other people with lived experience, and also practitioners and nurses and other people, is that that it's it can become a real conflict, I guess, in respect of we're kind of dictating to people that whilst you're with us on an NHS site, which may be an acute hospital or it might be an inpatient ward, that you're going to stop smoking. But we don't follow other or promote other healthy lifestyle options whilst people are either visiting the hospital. So some hospital atriums have fast food outlets in it. What kind of message are we creating there? When people come and stay on inpatient wards in mental health settings, we're encouraging them to use e-cigarettes or other nicotine replacement ways of helping them to stop, but yet we're feeding them food that's full of salt, sugar and fat. So it's a very kind of contradictory message, and I think that that people who do smoke aren't aware of different types of medications that can help them to quit smoking. When you go and see a GP, you're lucky if you get sort of 5 to 7 minutes with a GP, and you've got to pick and choose which aspects of your comorbid complex health condition that you're going to be speaking about. So I don't think GPs are probably in the strongest place to be able to enable and support people. So I guess what I'm identifying really is that it's a really complicated process that doesn't really seem to be owned by either primary care or secondary services, and there may be smoking cessation clinics and things, but it's got to be what works for that person at that time. And if people are on inpatient wards and they're there for a short stay, maybe 2 or 3 days, we're saying you need to give up smoking and here's a different option, but then they'll go back out into the community and then they'll start smoking again. So it really is about who picks up the opportunity to continuously work with that person, whichever area of healthcare they pop up in, really.
Thank you, Kevin, and thanks for sharing your perspective. I think it seems to really chime in with the key findings from the literature review, and it's great to have that perspective in particular. Next, we're going to move on to Paul, who's going to share the policy perspective. But before that, we'll just put up the slide again about how to get involved. So if you'd like to ask Curtis or Kevin any questions or any comments on or reflections on their sessions, then please do add them into your question box. And also remember the hashtag is hashtag SMI, smoking cessation, and hashtag HW Alliance. Brilliant, thank you. Paul, over to you.
Thank you. And thank you for inviting me to come and talk. I think trying to give the policy perspective could be very dry, so I'm just going to try and give a little bit of background. It builds a little bit of what Curtis has said in terms of smoking and mental health, but also about the long-term plan and what we're trying to do moving forward with the long-term plan. So as per some of the previous documents published by the NHS, the long-term plan does highlight prevention, but at this time we're trying to do something really different. We're trying to really do something proactive around prevention and actually help people move forward, which is why we're particularly focusing on tobacco addiction and the dependence that people have, and doing something proactive to actually start the ball rolling in secondary care and also in primary care and community care, but also in conjunction with local authority services. So why smoking and mental health? Well, there are huge health inequalities. It was highlighted before in one of the earlier slides. We know that people with common mental illness, there's 36% prevalence compared to a national prevalence rate of about 14.4%. That rises with serious mental illness up to about 40%, and that, again, when you combine it with poverty, can raise to 50%. And then in inpatient settings, there are reports out that says that 70% of people within an inpatient population do smoke. And there's something there about acknowledging that the NHS has a role to play. We know that some local authorities deliver smoking cessation services. We know that the NHS in different areas provides it. And we know that in some areas they just don't have a huge amount of service available to be able to access. So we need to do something bigger there. We know that in mental health, people die 10 to 20 years earlier than their peers. And we know that smoking is the biggest single cause for that mortality rate. So we know we have to do something. We know this is driving health inequalities. We know this is driving mortality. And there is an opportunity for the NHS to turn around and say, we've got patients in front of us. We've got the opportunity to do something, positive and to help people. And we know that people want to quit. Ash has published survey results before that shows that people are still worried about their health. They're just not given the opportunity. Again, that was highlighted in the slides. It's something that we have the opportunity to do something, and just reflecting on what Kevin said, it's about making sure that we're there when people are ready to do something. So we know that people want to quit, we know that they're worried about their health, and we know that they're not necessarily given the opportunity, but we do know that the medications do work, we do know that they're effective and that they're tolerated. So why aren't we doing it? And that's what we're trying to pull together with the long-term plan. We've looked at tobacco dependence across the board. We're looking at doing work not just in mental health services, but also in acute trusts and in maternity services, really trying to drive change to NHS perspectives to put this back onto the map and to actually turn around and say, we're going to stand up and do something for our patients. So we're putting new money in. We're focusing on secondary care because that's where a lot of the evidence about the interventions works. But we know that that's just the start of the journey. We know that we do need to branch out into community services and into primary care. We just need to understand what works best for people when we do that. I think what we want to do is be in a position in a few years' time that every person who comes into contact with an inpatient service, whether it be acute trust, whether it be mental health, is given that opportunity to beat their tobacco dependence. We know that part of it is an addiction to nicotine. It is a medical condition, and there are drugs, nicotine replacement therapy, that can support that. And what we can do is give people access to that at a time in their lives where something is happening and they're more likely to take on that opportunity to change their behaviours. We don't know what model will exactly work within mental health. That's why we're doing part of this work, and that's why we're having these discussions. We need to know what works and what works where, and understand that actually in different areas and for different people, different things will be the right thing to do. So we're putting money into the system. We're starting secondary care. We're going to put a model in that will make sure that people can access the pharmacotherapy, they can access that behavioural support. But one of the key foundations to that is that it can't be the NHS in isolation. It needs to be done in conjunction with local authority partners. It needs to be done in conjunction with the third sector. People need to be aware of that wider offer that's available to them. So from next year, we're working with a few sites to really test what we want to see happen over the next 3, 4, 5+ years. We'll work with them to put money in to turn around and say, right, we're going to do this in inpatient settings, but then we need to understand what happens when that patient walks away from a forced abstinence within an NHS trust because it's smoke free. What happens when they go home and they're right back where they started with all the social cues that help them smoke in the first place? And then we need to take that learning and just understand what we can do. We need to look at what's already happening in the system. Nothing that we're planning on doing is rocket science. Somewhere they're already doing something and it's working really well for that local population. So how do we find that, acknowledge that, and make sure that everybody else can turn around and say, well, we want a piece of that. We want to roll that out. And it's about acknowledging that it's about the pathway. It's you mentioned patient flow, Kevin. It's not just about looking at medicalising what happens in inpatients, chucking a load of nicotine replacement at people and saying, there we go, we've helped you, off you go, start the rest of your life. We need to make sure that it's acknowledging that these people might need 3, 4, 5, 6, 7, 8, 9, 10 attempts to quit, but it's about being there when they're ready and actually supporting them to do that. And it's about making sure that they don't fall between the cracks when they leave hospital or when they're in community services and they leave those services. It's about making sure that there's a pathway for them to progress onto, and we just want to know what works, and we're willing to learn over the next few years.
Brilliant. Thank you very much, Kevin. So we're going to be moving on now to question and answer section. I'll add up the slide again about where you can add in questions. We've already had some great ones in so far, so please do keep them coming. Peter, do you mind adding that slide onto the screen? So again, we can please do email us, add the question feature, or tweet as well. Brilliant. So we've heard from all the speakers. I think I'm going to start with one of the first questions around sort of where have we seen particularly different trusts or different examples where people have successfully led smoking cessation change in their own organisations. And so Paul, I don't know if you have any particular reflections on this from sort of your work at NHS England that you'd like to start with?
Say the question.
So are there any particular examples of where you've seen successful change or something that we
I think
learn
there's
from?
lots of isolated good examples of different bits of practice. I don't think I could turn around and say, here's one trust, they're doing it amazingly well, let's photocopy exactly what they're doing across the whole of the NHS. And it's about actually recognising that a trust in rural Cumbria might want a very different service to inner city London. So I don't know there's one trust. We do know that there's areas, South London and Maudsley are one that are held up to me. I don't know exactly what they do there, and it will be fun to learn what they're doing there. But we're going to be working with a couple of early implementer sites next year to really sort of test this out. We're going to work with sites that are across a large geographical footprint that have different rural and urban areas, and they will sort of test different aspects of what we want to do, and they will actually give us that learning, and at the same time we'll be able to promote what they're doing, share what they're doing, and then hopefully promote other services to step up and say, actually, we've done that, but we've done it in this different way. And I think it's recognising that not one sites will have the answer for everybody, but what hopefully we'll be able to do is a menu of interventions or something like that. I don't hide away from the toolbox issue analogy, but so making sure we highlight where we know there's good practice and go to. But if people do know areas of good practice, please do get in contact through the email address.
Absolutely.
And such.
Brilliant, thanks, Paul. So next we have a question which I'm going to ask Kevin around how best we can support and encourage people to take part in smoking cessation services.
How can we best encourage people to
take part in smoking cessation services? So are there any particular reflections from sort of your work that you've done in the areas? What can we do to encourage people to take part and stop smoking?
I think it's about creating the right conditions for change. So as I alluded to earlier, it's addressing the reasons why people smoke or why people choose to smoke, and when it's seen as by the smoker a therapeutic intervention, i.e. it helps them to manage stress, it helps them to manage their mental health, then we need to be looking at the reasons as to why that is. And as I said earlier, some of it's about chaotic lifestyles and not living in stable environments and not getting a joined up service. So I think it's looking at the person. It's not a one size response that, so we need to look at people individually and see what's going on for them in their lives. Try and understand why they're making that choice. If they feel that it is a choice, because it's also an addiction for some people, so they feel that they may not have a choice in that. And it's about giving people the best opportunity to be able to make the choice to give up smoking. And it comes back a little bit to the patient flow bit about, I think part of the answer to the question you had before was, I'm sure there is a perfect service out there, but it exists in different bits all over the country. And if we could identify all of those bits that work well in different areas of engagement and put it together. So I think it has to be tailor-made for the individual. It needs to be something that benefits them. A lot of people will say that they smoke because they're bored. They like going through the process of making a cigarette and smoking it, and some other people will say that they find it's soothing, it's calm. Whether there's any scientific evidence to prove that, I don't think there is, but it's about people's perceptions, isn't it? And if that person perceives that smoking a cigarette is good for their mental health, then we need to be honest and acknowledge that. But it's also about poly use of substances as well. So if people are drinking and smoking, those two substances complement each other really well in respect. So it's just remind me of the question again.
Yeah, so it's around sort of how we can encourage people to stop smoking.
Okay, so it's about incentives then, isn't it? And I think part of the incentive is giving people real life information that can help them make an informed decision. So I think about, I certainly know when I stopped smoking, my taste improved, my sense of smell improved. I was able to reduce my medication by 50%, which meant that I carried less weight. There's all sorts of health benefits, but if we're not addressing the negative causalities of the reasons why people are smoking, if we don't deal with that bit, then people are never going to get to the point where they feel that they're able to give up smoking.
Yeah, brilliant, thanks, Kevin. Does that resonate with you in terms of the research to date and the literature review that you've done?
Yeah, absolutely. I think from the perspective of what is out there already, in terms of the workshops, people spoke very much about the timing being right. And if the timing's not right, then being asked about whether they're ready to quit smoking almost feels like they're being nagged rather than it being a positive approach and encouraging in that way. And that's certainly something that sort of comes out of the Care to Quit study, which was a preliminary small-scale study that was focused on finding a support person, which might be the person's partner or family, another family member or friend, and then giving them the skills to encourage the person to seek out smoking cessation information, not just necessarily the different services. And that was very much around tackling some of the misconceptions and myths around mental health and smoking. And I think that again comes out in the literature review, the workshops, the surveys, is the kind of misconceptions that are held by family and friends, but also professionals working in mental health. So I think those are some of the areas that would be really useful to try and focus on and tackle. And those, I think, can be done now rather than later, and maybe don't cost very much to implement as well. But equally, having a collaborative approach where a person is given the opportunity to say, what their concerns are, what they feel would work, and having all the options available to them is, again, something that not everybody has experienced, where they may just be offered patches or gum, but actually there's better options out there in terms of pharmacotherapy and medications that just aren't prescribed to people.
Yeah, and I think that reflects one of the questions that's come through from Nora, which is around whether, should we have smoking cessation drop-in clinics within mental health services and within sort of those clinics in particular. Kevin, I don't know if you have
I just wanted to support a little bit of what you said, because I think, adopting a culture of non-blaming and non-judgmental of people who choose to smoke is really important. And also it's about not setting people up to fail. So if you're delivering smoking cessation classes or interventions to the service user, if they're going home, their family smoke, their partner smokes, they hang out with their neighbours smoke. It's about, actually it's about what's good for everybody and not just that person with the severe mental illness. It's kind of like how we get society on board in respect of it's kind of everybody's business, I guess. When it comes to Nora's question about cessation drop-in clinics, absolutely we should have some form of clinic or intervention or a smoking cessation champion, to want for a better word. And also we should make those open to staff members as well, because a lot of people who work in mental health services who are staff members smoke themselves, and I think that adds another layer of complexity to the conversation, that you got staff members encouraging service users to stop smoking, but yet during their break they're nipping off site, maybe nipping off site unless they've got a hidden place like most staff do, and they're having a fag themselves, and then they're coming back onto the ward and they're smelling the smoke, and you sat there and you think, hold on a minute, you've been off and having a cigarette, I can't have one. So it's about that joined up message, isn't it, that we give people. But yeah, absolutely should have some kind of something on that's ward based, but again there needs to be that same kind of presence in primary care or within community mental health teams, that when that person leaves the ward, it's about the next steps. Who then is going to pick up the support for the individual to make sure that they, so for me it's about that, not setting people up to fail. And I think by having interventions like that, ward-based interventions are really good for people.
Yeah.
To briefly just to kind of touch on what you were saying about not setting people up to fail, I think one of the elements that does come out in the literature is around the use of harm reduction. So, cutting down before quitting, or using cutting down NRT as a first step, whilst you're kind of exploring how else you might take the smoking cessation intervention further. So I think that's a useful tool to have available and to provide people as an option.
Paul, I don't know if you have any reflections sort of how the smoking cessation and mental health services work together.
I think in a lot of places they are currently disjointed. I think that is an absolutely ideal way to make sure that we can draw upon the work that the local authority smoking cessation services do really well at the moment. They do really well with behavioural change support. There's lots of services out there that are incredibly helpful for people, but people only access them when they're motivated to actually access them. It's an opt-in service. Whilst people are an inpatient, they can't necessarily do that, especially within the mental health services. So actually having people to come in, sit down, maybe do some group therapy with people that are sat there in that environment, and being able to sit down and start to build those relationships and build that level of trust in a safe environment for someone, so that when they go home, when they're back in front of all those normal social cues, they can actually turn around and say, well, actually, I know who I'm going to, I know where I can go to for additional support, and that might be in addition to support that's put in by the NHS in primary care or in community services. And it gives the opportunity for people to start to, say, build the relationships, recognise that face. Sometimes that's as bigger motivation, is that you're going out and you know who you're going to be able to see, you know you're going to see them, you are going to follow through on that promise that you made a few weeks ago or a few days ago, and you go out and you meet them. So I think that's an ideal opportunity. It's also an ideal opportunity for the cross-pollination. It will help staff to get involved, it will help staff to sort of see how it can just be supportive, and those little bits of motivation. Oh, you're on day 3, you're doing really, really well, you're nipping outside, how about we come and make you a cup of tea, which just distracts you from thinking about what you're thinking about to go out and have a cigarette. And they will learn from having those people there, and having those people there will, I think it's invaluable for making sure that local authorities and NHS work together and actually start to develop those relationships.
What I see on NHS trust sites are, it's really difficult, isn't it, when patient service users have leave from the inpatient ward, and when they go on their leave, they're going to go and smoke. You know, like they might have some leave to go into the town or nearest. You know, it kind of, you know, it's really difficult. And you know, we've got staff groups who nip out for a cigarette, or you'll see a cohort of people with lived experience with the cleaning staff. You know, which kind of comes on to the barriers and the implementation of smoking cessation policies, and you know how they're kind of written and implemented, and you know, again, you know, I just see staff who don't particularly want to implement policies around smoking cessation because they're trying to build a therapeutic relationship with that service user. And you know, what they're doing is being not adversarial but quite challenging in saying, and there's rules here, and the rules are that you can't. It's that, you know, it's you know, when people are really struggling with managing their mental health problems, then you know, the last thing they want to be thinking about is you know, stopping smoking. So I think it's kind of how you have the conversation, and when you have the conversation is the really important part. And you know, if you are going to have policies and develop policies, it's about making sure the people who are going to be benefiting from that are part of the design of those policies. You know, it's that whole kind of co-production element of it, rather than the kind of, I've got something that was written in a room by a few staff members, and here you go, just crack on and implement that. And staff consistently feedback to me that they don't want to be implementing the policy because they're trying to build relationships. You know, it's you know, then you've got smoking rules within community settings. So you know, if you're in your own home and you're going to be visited by a mental health nurse, you know, you're not allowed to smoke in the house for up to an hour before the visit. You know, and staff feedback that they're quite happy to go in a patient's home, service user's home, irrespective of whether they're smoking or not. So it's really complicated, and I don't feel that a lot of policies have been designed correctly, and I think they're quite muddled and difficult to interpret, and even more difficult to implement, I think.
Thank you. So we have another question through from Samir, who has asked about sort of how we can address the wider determinants of smoking and poor mental health. So I know we talked a little bit about the impact of poverty on that as well. I wonder whether, Paul, you'd like to start in terms of talking about the intervention services to address these sort of wider determinants, whether you have a view on that.
It's difficult because I think the wider determinants are different for different people in different situations. So there has to be an element of tailoring the intervention to that individual. I think there's a key role for people within the NHS to think about what are the wider determinants to the health. Mentioned poverty, housing is always a key one, and we know that as part of the homeless population, that there's you're much more likely to be a smoker and have other substance misuse problems as well. So we need to be holistic in what we do. Back at the ranch where I work, we're looking at tobacco and alcohol together. How do we support people to do that at a national level? But in trusts, there needs to be that acknowledgement that Kevin mentioned it. We've got to tackle the reason why. Is it because everybody at home smokes and it's just the thing to do? What can we do that's novel? I mean, the NHS, we will treat the people that are in front of us. We're not very good at treating the people that aren't in front of us. And indeed, you could argue that's a public health function and that needs to be picked up by local authorities. But this is why it's key that we all work together, that we've got the new staff that are coming into the NHS that are going to work across the third sector and saying the social prescribers. They're going to have an absolutely key role to understand what's happening locally, that we can actually turn around and say, well, actually, we can do our bit as the NHS. We can link you into the bit with the local authority, and actually we can nip off your housing issues, this is other issues. But actually we know we've got a peer support group in the community that this person can put you in touch with, and we can maybe link you into some talking therapies and other elements that might be there for people. But I couldn't give you a list here and now to tick them off.
I think you picked up on a really interesting bit, and I think you know, one of the determinants might be that, you know, we're quite good at discharging people from mental health services. We're not very good at being inviting everybody into the conversation or the meeting around about how we discharge people, and that would be an opportunity to invite in a smoking cessation practitioner maybe.
Absolutely.
But also we make it really difficult for people to access mental health services in a timely fashion when they really need it, and that could be a determinant as why people continue to smoke. Because if you're saying, listen, you've got to wait 12, 18 months for psychological interventions, or you've got to wait 3 months for a care program approach meeting, or you've got to wait, we're not giving people the best opportunity. We're not conveying a message of, we care, of course we do, but we're not giving that person the best opportunity to do that. So I think it's about getting the discharge bit right. I mean, you're always going to struggle to get a GP into a CPA meeting, but there's other people involved in your care, whether it's health and social care, that you can, it's about giving that person the best opportunity to help them to succeed. And I don't think we do that very well.
I think part of the work we're doing to partly putting new money into the system and driving people to say, if you're going to take this money and we want you to take this money, you need to work together. You need to identify the service, you need to identify this pathway. They should be identifying that key person to put people in touch with. And now that might be very different in Norfolk and Suffolk to Cornwall, but that named individual that people could hopefully be able to pick up the phone to and just say, I'm having a bit of a wobble, can I just talk to someone, and that they can get them in. I'm not talking about everywhere having fast track services, that would be ideal, but we've got to recognise that there's constraints on the system, but we need to be able to figure out what works locally for people and give them the opportunity to access that.
Great. Curtis, do you have any reflections, particularly in terms of how different services work together, sort of even beyond sort of smoking cessation and mental health services, in sort of the review or in your work?
Yeah, I mean, I think many of the points have already been raised by Kevin and Paul, but certainly I think one of the things that needs to be coming out of the report is about emphasising this need for embedding mental health into smoking cessation services, but vice versa, smoking cessation to be embedded in mental health services. And I think that will make it easier to combat some of the issues that have been raised specifically by Kevin. I mean, I think that's it from my perspective in relation to kind of the issues that are faced in terms of accessing services.
Brilliant. We are almost out of time for questions, and in a moment we're going to go into closing reflections to the panel, so I'll leave you with that to think about that, but time for one last question. We've had two in from Eileen and Richard, which are kind of talking about particular stop smoking services or interventions. So around sort of things that could be put in place, like sort of not having smoking in particular areas, or sort of using vaping as a form of sort of minimalisation as well. I wonder if any of the panel has a particular reflection on those sort of policies that can be put in place, or different services.
I think it's good that that Aileen, is saying that her local mental health trust has relaxed the smoking policy. I think that having such a rigid set policy, again, that policies for the most part I'm aware of in smoking haven't been co-produced with the people who affect them the most, and that's not just a service user, it's a staff member that has to have the challenging conversation or stop someone from going off to smoke. Relaxing that, because I think we do need to revisit those policies and see if they are fit for purpose. And like I say, for the most part, I think they've been poorly written and even more poorly implemented in a way that certainly when staff members talk to me, or indeed services, they find it quite contradictory and confusing what's in the policy. So I'm not saying could we have one standard policy for the whole NHS, because that wouldn't work, but I think for me it's about maybe pushing the pause button and just revisiting the conversation within your own areas of the country, and just having a joined up conversation with other providers, public health, because I agree with you. I think it isn't just the business of the NHS, and it can't be. It needs to be everybody's business, but yeah, I certainly think that's a good idea.
It's the practicalities of it as well, and there's another report by Ash where it talks about what providers do on a typical day versus the best practice, and most people will say that we won't help someone to smoke on the hospital grounds, but and 60% will say that that's their best practice. But actually on 25% will say that's best practice, but typically 60% of people will on any given day take someone for a cigarette on the hospital grounds, even if when there's a policy in place to suggest that that shouldn't be happening. So I think there needs to be a common sense approach, like you're saying.
I think one of the secure units in Norfolk doesn't own the land around the unit, and the policy is you can't smoke on the NHS land, but yet when people get leave from hospital, they will walk the perimeter of that hospital with a staff member, and the staff member saying you can't smoke on NHS property, and they're going, but you don't own this property, another company does. So you know, it's again those kind of complexities and challenges come up all the time. So I think this is a good opportunity for us to kind of have a conversation about, you know, I don't think a one-size policy will fit everybody. Of course it won't, but I do think we need to apply common sense to this, because, you know, some inpatient wards will say, you know, they've now got lockers in a kind of an airlock bit of access in an inpatient ward where they hold on to your lighter and your cigarettes, and when you come out on leave or whatever, they'll give you that. I mean, I just think there's so many practices that are being implemented and some aren't, that it's really confusing for both staff and service users, and I think there needs to be some national guidance on this, really.
I said there is some national guidance. Unfortunately, we've been on a journey for the last 4 or 5 years to move to a smoke-free NHS, and that is the national policy. There should be no smoking on national grounds. And that said, I recognise that it's very difficult to enforce that, and I know there's lots of areas, and I suspect this is what's happening in Ireland. Instances that they've relaxed the rules locally to try accommodate the patients that are there. But that said, NHS-wide, we have gone down that route.
Well, maybe that can be the guidance. Maybe that could be maybe the guidance could be to allow local trusts to have a common sense approach to be able to how they apply the principles of a no smoking policy, because you know, it does cause so much tension between staff and service users and families, and you know, we are asking people at their very most vulnerable moments to be thinking about, you know, going smoke free, and you know, and of course we want people to live long fulfilled lives, but I think, you know, there needs to be maybe some, you know, some devolving of responsibility to say to trusts, you know, obviously we want everyone to be smoke free, but the who, the how, the where and the when can give a bit more freedom to those trusts around how they go about that.
Yeah, thank you. We're quickly running out of time, but I'm going to ask each of our panel to share a closing reflection from the discussion today and our different presentations as well. Paul, would you like to go first?
I think something Kevin said really resonated with me. It's that consistent approach, and I think I've repeated it a couple of times, so that's why I'm reflecting on it. We want to do what we want to do, and relating it to the smoke-free comment said, it's about making sure that we get that support to people as quickly as we possibly can do, but it's making sure that we can offer that support when it's the right time for the patient as well, and making sure that if that support works today and yet they relapse and they start smoking again in a few weeks' time, is that we're there again for them, and making sure that we consistently make that offer to people and do the best we can to help them be that tobacco independence.
Kevin.
I think for me it comes back to the patient flow bit about you know, wherever I may present as a person with a SMI who smokes, that every opportunity is taken to engage with me and have a conversation, a recovery focused conversation, not a blaming one, not a holding to account one, not a challenging one, and it is, you know, making that every contact count for me. But you know, as we've identified, there probably is a good service out there that exists in different parts around the country, but you know, if I need that support to follow me in and out of services, and I like the idea of having peer groups in communities of people, but there's many people who will be suffering with agoraphobia or social phobias who won't be able to engage and find that useful. So it's a range of different interactions and interventions that are tailored to that person, and I think the bit about making it everybody's business, not just NHS, where voluntary and third sector organisations and others can look at other ways of interacting with those people that give them the best chance to be able to quit smoking, should that be what they want to do. I think is the important bit, because there will be some people out there who are smoking and that is their choice, and we need to respect that as well.
Thank you. Curtis.
Yeah, I think I was struck again by something that Kevin said about making every contact count. And I think within that, one of the important elements is arming staff with the skills to be able to support people better, but also the knowledge of what is available locally, what is available in terms of the kind of smoking cessation interventions, so that the person they're working with therapeutically, I think, is an issue that's come up in terms of not wanting to cause conflicts in terms of, I guess, approaching someone around smoking cessation. So I think for me, it's going to be important around emphasising those elements in the final report, and hopefully those kind of recommendations that follow that can be taken forward to the relevant.
I think that's a really interesting point that you've raised there, because it is not just about setting up the service users to fail. If we don't invest in the staff and give the staff the training and the opportunity to engage at every point, then we're setting ourselves up to fail as well, aren't we? So that investment requires investment in staff to be able to give that advice and in the right way every opportunity. So yeah, fair enough.
We'll be doing that through the next year.
Good, good.
I think for me, my closing reflection would be just to really highlight the importance of co-production. I think a lot of the things that we think is right, or the things that we think it's just the way things have been done, we really just need to actually speak to the people who it affects. I think particularly the reflection on how it will impact relationships is so important, and definitely something that's made me really think about how sort of policies are implemented and we change practice.
And can I just come on to that? Because I think, you know, people will lose community as a result of giving up smoking. I know that when I gave up smoking, when the smoking ban came into pubs and I chose to not smoke, and I lost a huge amount of social contact. So, you know, we need to think about what we're going to replace that with. If people choose to not smoke and all of their friends smoke, it's you know.
Brilliant. Well, thank you very much. I want to thank all of my panel for joining us today, and all of you for tuning in as well. On the slide on the screen, which will be on there now, this is where you can find more information, so about the Health and Wellbeing Alliance and more about this work. Some particular resources on Equally Well about smoking cessation and severe mental illness, and also if you're affected by anything you've heard today, please do have a look at the resources and advice lines on Rethink mental illness as well. All these slides will be available after the webinar, so please do download them as well. So after this webinar, you will be followed up by an evaluation form. Please do fill it out, share any reflections, closing reflections or comments, or any sort of advice for us on how we can do these better. Last thing to do is just say thank you, and I hope you all have a good rest of your afternoon.
Thank you.
Thank you.
Bye-bye.